Good morning, this is Dr. Sandeep Patwardhan, and I'm here today to talk to you about the enigmatic elbow. Very often, we find that when we see a child, it's always an enigma when the child has a fall on his hand. The elbow is swollen, it's painful and stiff, and you get an x ray done. The x ray in your mind seems to have only two diagnoses, either a supracondylar displaced fracture or a type 3 lateral condyle, which are the by far the most commonest elbow injuries that you get in the pediatric age group. Supracondylar accounts for 75% of these cases, and lateral condyle is about 17%. But that just makes it 92%. 8% of the elbow injuries are osteochondral fractures, which are commonly missed. So the eyes don't see what a mind does not know. And my job here is to make your mind aware or open about the other injuries which are dismissed commonly as trash lesions. What is a trash lesion? A trash lesion is a swollen elbow with an innocuous or near normal looking x ray which might be thrown away in the dustbin thinking it's trash. But these are the injuries which will always need some kind of surgical intervention. And if you don't diagnose them right, they have serious long term complications. Let us look at some cases. This is a 9-year-old boy who came to me about 3 weeks after injury. This was his x ray. Elbow was swollen, painful, and he had restricted extension. And initially, he was treated by a surgeon who told him that the x ray is normal and was sent away. Now, on further investigations and drawing some lines, I found that the radial head was subluxated posteriorly. The CT scan revealed that there was an anterior head osteochondral fracture with a progressive posterior subluxation of the radial shaft along with the remaining head. And that was his intraoperative picture. So he had to undergo an open reduction for this radial head osteochondral fracture. After open reduction, we had to put a Herbert screw to restore the article congruity and reduce the shaft of the elbow and the remaining head back to its normal position. That was the intra-op video, and this was his post-operative imaging. That's his function at 3 months down the line. His pain has gone, the stiffness is gone, and he's back to his passion, which was boxing. And 5 years down the line, this young child is now a national level boxer, and we have removed his screw, and he's just doing fine. So this was an interesting trash lesion that you should be aware of. Another case, a 3-year-old with a swollen elbow with restricted supination. X-ray looks pretty innocuous, but additional imaging in the form of an MRI shows that it's a radial neck fracture with a completely unossified radial head. And you can see the star which shows you that the head is lying outside the joint. So it's a complete dislocation through the epiphysis of the radial neck. Now this will not be seen because on an X-ray, the ossific nucleus of the radial head does not appear till about 4 years of age. So radial neck fracture dislocation is another osteochondral lesion, also can be missed and you should be aware of. Now a 5-year-old, you can see this X-ray, child had a swollen elbow, a small bit of bone there, and this was diagnosed by somebody as a medial epicondyle fracture. They took the comparative X-ray on the opposite side and found that the medial epicondyle, which should be in the normal position, seems to be displaced. There is an option of treating medial epicondylar fractures conservatively, so this child was given a slab and sent home. This is what happened. But 2 months or 3 months down the line, the child was no better. He had a stiff elbow, he had pain, and you can see on the plain X-ray now there seems to be some calcification or ossification which is happening on the medial side. And eventually, this metaphyseal ossification suggests that the true diagnosis is a medial condyle fracture, not a epicondyle fracture. Like you have lateral condyle, the entire medial condyle can break and rotate along with the flexor origin with a little bit of metaphyseal bone. And that metaphyseal bone may be mistaken as epicondylar fracture because rest of the medial condyle at that age is completely cartilaginous. So medial epicondyle fractures are unusual in 5-year-olds. This ended up with a very bad cubitus varus and a stiff elbow with a flexion deformity like this, which could have been avoided. This was poor result. Another example, this is another X-ray with a swollen elbow. Always look at the medial soft tissue shadow. You can see a large soft tissue shadow with a small bony fragment, and an arthrogram may be able to confirm the presence of a large condylar fragment, which then needs to be open, reduced, and fixed like you do with the lateral condyle. 5-year-old, fall on outstretched hand, large swelling on the medial side, small flake of bone. An MRI shows you that the entire medial condyle is lying outside. So, have a very low threshold for getting further investigations done in the form of arthrography or MRI when you see such a lesion. The key point to remember is medial epicondyle fractures before age of 9 should be considered as medial condylar fractures unless you can prove them otherwise with additional imaging. The fourth case, this child was treated as an elbow dislocation. As you can see, the both radius and ulna are subluxed on the medial side. But what is the true diagnosis? The true diagnosis is a transfacial separation. Very young children or neonates, commonly mistaken diagnosis of elbow dislocation is made. How can you avoid this pitfall? Make sure that the radius and ulna are together, they are aligned to the capitulum, and they move posteromedially. The elbow dislocation moves laterally, whereas the transfacial separation moves medially. And you need to treat it like a supracondylar with reduction and arthrography and a couple of pins to hold the fragments in position. So this is how it was done. Just to recapitulate, a normal elbow alignment in an elbow dislocation, ulna and radius will go posterolateral. Lateral condyle, the radiocapitular line is disturbed and the fragment rotates. In supracondylar, the alignments are maintained and the fracture is in the metaphysis. But in a transfacial separation, you will see that it goes posteromedially and you may not be able to see the distal humeral physis, which is cartilaginous. Case 5. Here you can see that the elbow is swollen, and just look at the X-ray. It looks very innocuous. It seems as if there is no fracture. And this ultimately came after 4 weeks with a bad cubitus varus and a malunited Montegia, proximal ulnar fracture. And if you revisit the old X-ray, now you can see a small crack which was going in the proximal ulna, which was missed and ultimately was undertreated with a plaster and it displaced into a bad cubitus varus. This is a 10-year-old. Now you are seeing an older child and you can see that medial epicondyle is avulsed with soft tissue swelling there. Now medial epicondyle avulsion can be treated conservatively, but with wide displacement and a flexor origin attachment, especially in high demand young children with instability, it would be a good idea to fix it with a compression screw or a suture anchor. Sometimes this fracture also exists with fracture dislocation of the elbow. So if there is instability with medial epicondyle fracture, open reduction with a cannulated cancellous screw fixation will restore function to normalcy. Another example, 1 month post injury, child was treated for an elbow dislocation, swollen elbow, stiff elbow, and what can you see? On the medial side, you can see that the epicondyle is missing, but you can see interarticular ossifications there on the trochlear side. So you should be immediately suspicious that this elbow dislocation has a incarcerated medial epicondylar fragment. So an elbow dislocation, when it is reduced, there is a risk that the medial epicondyle with the ulnar collateral ligament can flip over and get incarcerated into the joint and can commonly be missed, and that will lead to a very bad outcome. So do not miss an incarceration. Get additional investigations like an MRI or a CT scan, remove the trapped fragment, reposition and fix it. Sometimes you have to excise it and do an arthrolysis to restore the elbow function. So this is what you can see in this picture. Even the ulnar nerve has got interposed and that was removed. The fragment was restored and a fixation was done so that the neuropraxia went away and the elbow stability was restored. Another case, The medial epicondylar fracture dislocation, reduction, and this child open reduction with cancellous screw fixation with a wire. Sometimes people have tried closed reduction followed by plaster, and you can get healing, but the elbow may remain slightly weak. Another example, an innocuous looking X-ray with a painful swollen elbow. The X-ray shows on the lateral a small lateral condylar fracture which is undisplaced. This is commonly treated with a slab, but at 4 weeks you can see that the fracture line has actually increased and you can see more lucency. And at 7 years, a complete frank non-linear. So what happened here? Now you must realize that never consider a lateral condyle fracture heal unless you can demonstrate osseous union. And the second message is the stage 1 of lateral condyle fracture has to be subclassified into type A or type B. And what is type A? Type A is where the medial cartilaginous hinge is intact. I'll show you some examples. Look at this X-ray. The metaphyseal crack is completely visible. But we have no idea where is the exit line of this fracture through the cartilage. Is it stopping short or is it going across into the joint and the cartilage is broken? Now this child was treated in a plaster and you can see it displaced and went into non-union. So this was a complete fracture through the cartilage which got displaced because of the extensor apparatus pulling out the lateral epicondylar region. Now another example, this child you can see that there seems to be a malposition of the lateral condyle with a large soft tissue swelling. Now an arthrogram was done and it was confirmed that there was a completely rotated lateral condyle and then it was properly treated with closed reduction and K-wire fixation. So there's always this dilemma, a type 1 lateral condyle, should I fix it or should I trash it? Okay, and how do you identify? You investigate. What are the investigations? An MRI. MRI shows you in this particular case that the cartilage hinge is intact and this is type A which is stable and can be conserved and goes on to a nice healing. But a similar looking X-ray on the metaphyseal side shows you on MRI that the cartilage hinge is broken. Now what happens is that within a week synovial fluid leaks into the fracture, the hematoma is diluted and the extensor muscles are pulling this fragment apart. So when the plaster becomes loose in a week, the fragment displaces and this will not heal and goes into non-linear. Dynamic examination with an arthrogram is always useful. You can see the gap opening up on varus stress and this needs to be fixed with a K-wire to prevent this complication from happening. Another case, an adolescent child, innocuous looking X-ray, swollen, was treated in a plaster, came back with a painful stiff elbow. A true dead lateral taken at 4 weeks shows you a shear fracture of the capitulum. The CT scan confirms that this was a shear fracture of the capitulum, which was open reduced and fixed with Herbert screws, and the articular congruity is thus restored. Another trash lesion, a 9-year-old national swimmer who had posterolateral instability on doing backstroke. X-ray looked innocuous, doesn't seem to be anything wrong on the plain X-ray. But if you look closely on the lateral X-ray, there seems to be a small avulsion behind the lateral condyle. And further investigations like an MRI showed that this was a sleeve fracture. So an osteochondral posterior capsular sleeve fracture of the lateral condyle. And this was connected to the capsule and the radial head used to subluxate because this was not healed up. So we had to open reduce, freshen the edges and fix this with Herbert screws so that we tightened up the posterolateral corner and this healed in 3 to 6 weeks and the child is back to normal state. So what are these trash lesions? This is a group of osteochondral injuries which if treated insufficiently always result in chronic long-term consequences. A prompt diagnosis and a high level of suspicion with early additional imaging is mandatory. All of them are displaced and unstable. They require anatomic reduction and internal fixation with soft tissue diffraction. Additional imaging in the form of ultrasound, which is inexpensive, or an MRI or an arthrogram as per your availability should be used to diagnose these lesions. Don't trash a swollen elbow in a child Remember that supracondylar fractures and lateral condyle are not the only injuries around the elbow. Use additional investigations as per availability, affordability, and your experience. And always be ready for surgical intervention. We have published our series of trash lesions, a review of approach to diagnosis and management in the Indian Journal of Orthopedics in 2021. It would be worthwhile to go through this paper. Original paper by Peter Waters and James Castle from JPO 2010, where they have given a list of the trash lesions, osteochondral fractures with joint incongruity, radial head compression fractures with subluxation, Monteggia variations with subluxation, lateral condyle avulsion or shear fractures, non-ossified medial condylar fractures, transfacial separations, trapped epicondylar fractures, and complex fracture dislocations. Please remember the ossific centers around the elbow and when they appear and when they fuse so that you don't miss these osteochondral lesions. The mnemonic credo everybody knows, lateral condyle at 1 year, medial epicondyle at 5 years, radial head at 3 years, the trochlea at 7 years, and lateral epicondyle which comes at 11 years. So now that you know these trash lesions, please make sure that you don't trash a swollen elbow with an innocuous looking X-ray and make sure that you diagnose them correctly. Thank you very much, and I'll be happy to answer any questions.